May I kindly ask you to be seated? Thank you. Very good morning to everybody. Good morning to those who are in our meeting room and also those who are connected online. My name is Remik Barańczyk. I work for the Euratom Supply Agency, and I will have pleasure today to chair this special event before the RRFM. I am here also with the distribution experts and also with my colleague Cora Blankendahl from the Energy Palace to help me later with the session on questions. Sort of the introduction, as you all know, or most of you know, isotopes play a vital role in the life of all of us. Every year in Europe, 10 million patients benefit from the medical isotopes. Last decades, we observed the huge development. We see also that quite a lot will be happening in this domain in the years to come. So therefore, we are organizing this session, first of all, to look into details. What is the current situation? We will also try to describe the outlook, what is in front of us in terms of the nuclear medicine, and also look at the challenges in the supply chain. We will also at the end try to figure out what is necessary at European soil to be established to have very robust supply chain. Let me also mention that this is the second event organized by ENS, second event on medical isotopes. The first one took place last year in Budapest. That time we focused more on the molybdenum technetium, which is the workhorse of nuclear medicine. This time we will be focusing more on the therapeutic medical isotopes. So you will hear quite a lot about theranostic. I think we are very timely on this because the 31st of March was the World Day of Theranostic. So I think it's a very good selection of the date and the topic. To set the scene, we will start with the short video, and I think from this video you will understand why the organizer decided to title this session Turning the Tide with the Medical Isotopes. So may I ask for the short video to be presented?
Deze medicijnen zijn voor mij zo belangrijk. Als het er niet zou zijn, dan denk ik niet dat ik nog geleefd had. Ik word er bijna een beetje emotioneel van, maar het is wel zo. Ja. Door dit leef ik nog.
Deze isotopen worden gemaakt in een kernreactor. Door materiaal dicht bij de kern van de reactor te leggen, verandert de grondstof in een radioactief isotoop. Na bewerking kan het radioactief medicijn worden ingespoten bij de patiënt. Voor gebruik van het middel wordt een stof toegevoegd die alleen bindt aan een bepaald eiwit op de tumorcel. Hierdoor hecht het isotoop alleen op de kankercel en nergens anders. Vervolgens vernietigt de radioactieve straling deze cellen, waardoor de tumor verdwijnt of kleiner wordt.
Goedemorgen.
Goedemorgen.
Welkom weer. Want u komt vandaag weer voor de volgende lutetium-PSMA-behandeling. Ja.
Een spannende dag voor Johan Drost. 16 jaar geleden wordt bij hem uitgezaaide prostaatkanker ontdekt. Vandaag wordt hij in het Antoni van Leeuwenhoek ziekenhuis in Amsterdam voor de 3e keer behandeld met lutetium-PSMA. Een radioactieve stof die de tumoren in zijn lichaam heel specifiek aanpakt.
Het enige wat ik van merk is dat mijn kwaliteit van leven en ook mijn conditie en dergelijke enorm omhoog is gegaan. Ik wandel elke dag weer een paar kilometer en dergelijke. Als u nagaat dat ik vorig jaar heb ik contact gehad met een hospice om daar mogelijk naartoe te gaan. Ja, het is niet te geloven. En nou wandel ik een paar kilometer. Dat is voor mij een enorme boost, dit middel.
Dagelijks maakt nucleair geneeskundige Wouter Vogel mee wat de impact is van medische isotopen bij het opsporen en bestrijden van bijvoorbeeld prostaatkanker.
Prostaatkanker heeft een heel bijzondere eigenschap. Er zit, op de tumorcellen zit een klein eiwitje en dit geneesmiddel dat klikt daaraan vast. En zo brengt het de straling precies op de goede plek.
Oké, dus andere cellen die blijven dan gewoon ongemoeid?
Andere cellen in het lichaam hebben dat niet of nauwelijks, dus daar komt bijna geen straling.
Thank you very much. So I think it's also very important that we are starting with the patient. It's crucial in all those discussions that remember that all about is here about the patient. We are also very lucky today because the medical doctor from this short video is with us. Dr. Wouter Vogel, he was trained as a medical physician, medical nuclear medicine physician and also the radiation oncologist. So I think it's a very good combination, and we have a guarantee that we will have unbiased helicopter view on nuclear medicine. So that's very good. Wouter is working for the Dutch Cancer Center, and his main field of expertise is non-invasive diagnostic and also treatment of prostate cancer using both medical isotopes and external beam radiotherapy. So in this presentation, Wouter will look at the nuclear medicine from the perspective of the patient, and he will tell us what are the situation nowadays in the nuclear medicine. So Wouter, floor is yours, 20 minutes, please try to stick to the time.
So good morning to all of you, and thank you for the kind invitation to discuss the use of medical isotopes for the treatment of cancer. I'm looking for the clicking device. It's not here. Yes, thank you. And it's working. Yeah, so I'm just a medical doctor. I try to treat patients mostly for prostate cancer in the Netherlands Cancer Institute in Amsterdam. And I would like to start from the point of view from the patient that we just saw in the video. You noticed that the patient was at some point quite emotional. And why is that? Because prostate cancer generally has a very good prognosis. We are able to cure most patients with prostate cancer. Okay, some patients get metastatic disease. They can no longer be cured, but we still have a spectrum of viable options for them to live a long and a good life. But still, about 400,000 men per year globally reach a phase where the disease no longer responds to any of the current treatment options that we have. And in this situation, the patients start to suffer from uncontrolled tumor progression throughout their body. And this comes with pain, especially when they try to stand up or walk. Their condition starts to go down. Their quality of life starts to go down. And in the end, they can die from the disease. And this is the phase where this patient was in when he presented to me. So how can medical isotopes help a patient like this? So in order to understand it, I'd like to discuss what is happening in oncology at this moment in general, then look at how we use medical isotopes for diagnostics, for treatment, and last, what happens if we don't have medical isotopes available. So first, the general developments. Oncology treatment was a one-size-fits-all until recently. But now we are better able to identify the characteristics of a specific patient and the specific cancer this patient has. We understand the tumor biology and we are able to adapt a treatment specifically to this tumor. Then we are also able to guide a treatment specifically to the tumor alone because we can now see the tumor directed to the cancer and not to healthy tissues. And we are increasingly able to offer the patient options to choose from, which is very important for their quality of life, to choose the treatment that fits their needs. But the most important one in this perspective is the molecular biology. We increasingly understand how the human body evolves through the span of life, and that this is not a static process at all. Inside the body, there is a spectrum of molecules, cells, hormones, signals moving throughout the body, and this is dynamic through life. And it all changes again when a person at some point gets a disease, like cancer. So how do we even know this? And how can we use this to diagnose a disease or to treat a disease? This is because we have medical isotopes. Firstly, for diagnostics. For example, we can now select one specific molecule in the body, like glucose, label it as a radioactive pharmaceutical, inject it, and then scan and see where this molecule in the body goes, what its functions are, in which organ systems it arrives, and also how this changes when a patient gets a disease like cancer. And this in a whole body overview in a quantitative approach. That is really unique. And also important, it's easy. It's straightforward. From the image on the right, you can tell as an untrained observer that this patient has cancer and where it is localized. Molecular imaging is an easy concept. And this really helps us to detect, for example, cancer, to stage the disease, to see where it is localized, to characterize the disease, how fast it's growing, to guide further diagnostics to the locations of the disease, and to guide to select the optimal treatment, and also see the response to a selected treatment. So this is a great help to understand disease and manage a disease. And this was a generic tracer, glucose metabolism. But now, for the first time, we also have very selective tracers that can see a type of cancer using a labeled molecule. This patient has metastatic prostate cancer. And the PSMA ligand that is used and that is radio-labeled connects only to prostate cancer cells. So this once again provides a whole body overview of the patient and his disease and the extent. And you can see it as an untrained observer and have a very quick understanding of the situation. And it's important to understand that prostate cancer has always been one of the most difficult cancers to see, because prostate cancer cells still look a lot like and behave like normal tissue cells. But now finally, we found the characteristic that allows us to discriminate them and to see the disease. This has changed a lot. Prostate cancer is now one of the easiest cancers to see because of molecular imaging with medical isotopes. Another example of non-specific imaging, we also better understand what is happening inside cancer. There's not just tumor cells, but also the response of the body to the cancer. And this can also allow us to see cancer in a non-specific way. And that allows us to see a variation of cancer types that were hard to see before. And so this is just to provide you with an overview of the possibilities that we have now and that are upcoming. We expect that molecular imaging will allow us to see virtually any cancer in the coming decade. Another example that it's not just limited to detecting and seeing and staging a disease. You can make anything radioactive in the human body. For example, a hormone, a cell type, or a therapeutical, like medication. In this patient, we have made chemotherapy cisplatinum radioactive with platinum 195M. And this allows us for the first time to see how chemotherapy distributes in the body, if it even arrives in the tumor, and if it's likely to help the patient or not. And until now, we've never been able to see chemotherapy. So this is new information that we never had before. And this will help us to select the right treatment for the right patient again. So in conclusion, for diagnostics, the visualization of molecules inside the dynamic human body really helps to detect disease and its characteristics, to find the right therapy, guide the treatment to the right place, and to monitor progression or response of the disease. And we do this every day already. We use a lot of medical isotopes for this every day. And then there's the next step, to use this for treatment. So anything that you can see selectively on a PET scan binding a medical isotope with a low dose is potentially also available to treat with a high dose of the isotope. So this leads to the theranostic image-guided treatment concept. First, you make a scan, you see a specific molecule accumulating in the cancer, and then you increase the dose to deliver a treatment radiation dose in the tumor. And this is a systemic treatment, so it reaches every tumor location in the body, wherever it is. And it's generally very effective because it targets all the tumor. And it's also very low toxicity because the radiation does not end up in normal healthy tissues. Some examples. This is a patient with a neuroendocrine cancer. And in the patient on the left, you can immediately see on a gallium-68 scan that the patient has cancer, and this is widely spread through the body. It's bulky disease. The patient is not feeling well, probably has pain, and is in the last phase of his life. In the middle, you can see that we gave a therapeutic dose using lutetium-177. And you can see that it actually arrives in the cancer and it gives its radiation energy in the cancer. And in the image on the right, you can see a few months after that the cancer has diminished enormously. There's hardly anything visible left. And you can appreciate that this patient is probably feeling a lot better. And this kind of treatment on average leads to a longer life, up to a few years even, with maintaining the good quality of this life. Now, this was an example that we have done for years now, but it was for an exceptional tumor type that we had a molecule binding to, the neuroendocrine cancers. Now, for the first time, we have a molecule that binds to a large group of cancers, the prostate cancer. In this image, once again, you can see that the prostate cancer has disseminated through the whole body. It binds the molecule in a very high level. And then we can give repeated injections of a high treatment dose using lutetium-177. And after a few months, you can see that the tumor has responded enormously. Now, it's good to understand that this is a treatment for patients who have tried every other treatment, but everything is then failing and there are no other treatment options left. Those patients can still respond to a treatment with medical isotopes and have a longer and good quality of life. We know this from research. Not every patient responds this well, but in about half of the patients, the blue bar group, you can see that the tumor decreases enormously, where there was no other treatment effective at that time. And this illustrates that patients also live longer on average. On average, it's about 5 months, but those patients that respond may respond for up to a year or even longer, added benefit of life with good quality. So let's go back to our patient. He presented at the end of 2021 to me with the extensive disease, and he was looking at the end of his life and aiming to spend his last months in a hospice setting. But then he received 6 doses of 7.4 gigabecquerel lutetium-177 PSMA therapy. And within a few months, he returned to a very good quality of life, and he canceled the hospice and just resumed his normal life. And 1 year later, and a few repeated treatments later, he was still in a very good condition. And this is where he volunteered to contribute to a TV to spread the word that this treatment is working. And I would say after 1 year of treatment, this patient has a very good and meaningful life. Another future example, just to show it's not prostate cancer alone, the FAPI ligand molecule that binds to virtually every cancer by binding to the tumor microenvironment in the body. It can also be seen on the scan on the left, and it has also been targeted with a therapeutic isotope, in this case, samarium-153. At this point, we don't yet know if patients also live longer due to this treatment. It's ongoing research, but this illustrates that we will have a spectrum of molecules targeting a spectrum of diseases, and that can be labeled with a spectrum of medical isotopes. The future is promising. So the therapeutic value, in summary, we can treat many different diseases with medical isotopes. We can personalize the treatment by selecting the right patient, first show that the molecule targets, and find the optimal dose of the treatment. And using these techniques really improve survival and quality of life for patients. Now, this is leading to a huge increased demand for lutetium-177 and also a spectrum of other medical isotopes, like, for example, actinium, terbium, lead, platinum, whatever. This technique is rising, and therefore the demand for medical isotopes is also rising, and it is anticipated to be huge for the coming decades. And that brings me to the last point that we need to cover. What happens in medical care if the medical isotopes are not available? In a diagnostic setting, the patient will not be able to get a specific kind of scan. That may lead to a delay in the diagnosis or maybe a bit suboptimal diagnosis. We will find other scans that largely cover the question as good as it gets. And there may be a bit of a delay also in the start of the treatment. And potentially, it's not in all cases the perfect treatment, but still we can manage. But it leads to stress in patients. When you are confronted with a diagnosis of cancer, you don't want to wait for a scan. That leads to a tremendous amount of stress, even though we can manage without the scan. But in a therapeutic setting, it's worse. Patients, they know that they are still alive because of this treatment. So if there is delay or canceling of scheduled treatments, then patients their condition will get worse. And if the delay is long enough, they may eventually die. And patients know this. And this is the last thing that you want to happen to patients in the last phase of their life, to know that there is a treatment that can help them, but it's not available. This leads to severe stress in the last phase of life of patients with cancer. So therefore, in conclusion, medical isotopes have now a fundamental role in current and future medical care. And they are also fundamental to learn more about diseases in the coming decades. And we need a very robust supply chain with sufficient volume of all the isotopes that we need to live up to the future expectations. So this is the current position. And thank you for your attention.
Thank you, Wouter, for your excellent presentation. I think that's a very good introduction to our discussion. We see how important is nuclear medicine. You are really turning the tide for millions of patients. I'm also happy that your patient is doing fine. We have a time for, say, one burning question. Make good use of it. You don't often have a medical doctor here, so please go ahead.
Okay, thank you and congratulations. The question I have is, what volumes are we for the diagnostics? It's pretty well known, but for the therapeutics, because they are much more targeted, what volumes, what number of patients are we talking about, and how do you see this evolution?
Yeah, that's a very good question. We are only at the beginning of this, and I can give the example for prostate cancer and prostate cancer alone. In the Netherlands, we have about 3,000 patients who die from prostate cancer every year. They don't all have the nice PSMA targeting, say 2,000 patients per year. And they need 4, 5, or 6 injections of lutetium. So that adds up to about 10,000 injections of 7.4 gigabecquerel lutetium PSMA. At this moment, we treat less than 10% of this, because in the Netherlands, the capacity of labeling procedures, treatment rooms, imaging devices, it's all yet limited. And we have to invest and expand this. And if we do that, we increase our capacity, then the lutetium demand will also increase tenfold. And this may happen throughout the world. And then we may discover molecules for other cancer types, and it may again increase tenfold. So at this moment, it's not that big yet, but the potential is quite large.
Okay, thank you very much. I think we have to move to the next expert. Let's move from the medicine to physics. I think this is something which is closer to your hearts. So in front of you, you have Professor Michael Kohler. He was trained as a medical physicist, and in '97, he got PhD on quantitative nuclear imaging. In 2014, he was appointed as an associate professor in quantitative molecular imaging at the Catholic University of Leuven. In his research, he focuses on always towards maximizing the clinical potential of newly developing imaging technology for the benefit of patient. And most importantly, since January this year, he is the scientific liaison officer within the board of the European Association of Nuclear Medicine. So, Michael, please talk about the physics technicality of the nuclear medicine and also describe the current situation of the nuclear medicine in Europe. The floor is yours. Thank you.
Okay, thank you for the introduction. I try to be complementary to the presentation of Wouter, and I will give you a bit more technical information and give you an overview of nuclear medicine. So I would like to start again by saying that in nuclear medicine we have diagnostic and therapeutic radiopharmaceuticals, but basically both are based on the same mechanism. We have a molecule that we know has uptake in a specific organ or a specific tissue. And so we will label that with radiopharmaceutical, but if we want to develop a diagnostic radiopharmaceutical, we will basically choose a radiopharmaceutical that is able to generate high energy gammas, which can penetrate to the tissue, and so that's why we can also detect it outside of the body. If you want to use a therapeutic radiopharmaceutical, it's basically the other way around. We are not so interested in detecting the radiation outside of the body, but we just want to make sure that we have a radionuclide that is able to generate a short-range, high-energy radiation such that the targeted high dose can be delivered to tumor cells. And so first, looking at the diagnostic radiopharmaceuticals, I first want to stress actually that nuclear medicine is a very sensitive technique and that we actually only need a limited amount of radiopharmaceutical. So we don't induce any pharmacological effect when we are administering the diagnostic radiopharmaceutical. And one example I want to show here is, for instance, carfentanil. That's a very strong anesthetic. You use this when you want to put a large animals asleep. But we can use this as a PET tracer without causing any harm to humans. And so that's perfectly safe. So which radionuclides can we then use for nuclear medicine? We can there make a distinction between two types of radionuclides. We, on the one hand, have single photon emitters, which are generating a single gamma photon with one specific energy. That's also called conventional nuclear medicine. And on the other hand, we have positron emitters, which are generating a positron, and that positron is annihilating with an electron, and that's basically generating then two photons which are traveling in opposite directions. And that's then called positron emission tomography. So looking at conventional nuclear medicine, also there technetium is still the workhorse of conventional nuclear medicine. It constitutes about 80%, if I still can go back. Oh yeah, it constitutes about 80% of all nuclear medicine procedures today. It's used so frequently because it has convenient properties. It has an energy of 140 keV. It has a 6-hour physical half-life. And so if you look here at the applications that it can be used for, it's quite extensive. But also here we have to deal with regular shortages of technetium. And that can be both planned and unplanned. So like last year, even during the month of November, we had an unplanned shortage of technetium, which again, as Wouter was already mentioning, has a direct impact on patient care. And so next to technetium, we also have other isotopes that we can use in clinics. We have the iodine family, so the iodine 123 and the iodine 131, which we also use for therapeutics. And then we also have the indium. So how do we use this now for imaging in nuclear medicine? First of all, we have the planar scintigraphy. That's the procedure that is used the most often. It's also the most straightforward, where basically we pass a detector at the back of the patient and in front of the patient. And then you can also see the differences in intensity. So you can see here the spine, which is clearly visible on the anterior, on the posterior view, and it's less visible on the anterior view. And you can also here see that you have a superposition of different structures. Yeah, that's not the latest version of my presentation, actually. So I have to apologize because I'm probably losing a bit of track here. What's important also, if we are using conventional nuclear medicine, since we are only having a single photon, we also have to use actually a detector, a collimator. And we have to use this collimator actually to make sure that if we detect the radiation, that we know actually where the radiation is coming from. And so that's quite important. The only drawback of this approach is actually that we will only detect a very small fraction of the photons that are being emitted by the radionuclide. And it basically means that we have a very low sensitivity. We can, of course, increase the sensitivity, but then we will lose resolution. So that's always a bit of trade-off between sensitivity and resolution. Most of these systems are also optimized for technetium. And so we can tweak these systems again by changing the collimator. So we have a collimator for lower energies. We have a collimator for higher energies as well. And so this collimator is basically just a chunk of lead where small holes are drilled into. So that's basically how we do the imaging. So these camera systems are also increasingly being combined with CT. And the advantage of CT is that we can also give some anatomical information to the medical doctor. So it's much more easy to localize tumoral lesions. And that's actually appeared to be superior for different cancer types. This is again my latest version. Okay, cool. This is actually how then the different configurations that are available. You can have a one-headed system, you can have a two-headed system, a multiple-headed system. Of course, that also increases the cost of such a system. You can also use it in different configurations. So this is a 90 degrees configuration because we always want to have the detector as close to the body of the patient as possible to maximize the image quality. And this is then the different sets of collimators that you can use depending on the energy of the gamma photons. And so it's, as mentioned before, it's increasingly being combined with CT. And so that also will increase the quantitative properties of SPECT. There was also a movie there, but I don't think it's working. So what is now new in terms of conventional nuclear medicine? Actually, now we have different type of detectors. We have solid state detectors, which can make this detector much more compact, such that we can have an integrated collimator. And that is shown here. I don't think that the movie will be working. Oh, it's working, yes, perfect. So in here you see how it works in practice. So we have a very small detector heads. They can come much closer to the patients. So we can increase the image quality. And we can also increase the sensitivity because we have much more detector material close to the patient. So that basically means that we can increase sensitivity. The disadvantage is that we are limited to a fixed energy range. So it's much more difficult to image the high energy gammas. Also that, but one of the advantages is that we can dramatically reduce the acquisition time. So if we need 1 hour for a whole body SPECT CT scan, we can now reduce this with a factor of 3 and only have like a 20-minute scan. But of course, the investment is substantial. So if you look at the current state-of-the-art SPECT CT scanner, that is around 600K, sorry. For such a CZT system, you have to double the investment cost. But anyway, these systems are becoming much more important also in the terms of dosimetry and diagnostics. So then we come to positron emission tomography. So till now, we have used single photons. With positron emission tomography, we can actually use both photons. And it basically means that we don't need a collimator. And that means also intrinsically a higher sensitivity. And the resolution is also much better. So we are here at a resolution of around 5 millimeters. And from historical purposes, that's also fully quantitative because they try to make it as quantitative as possible from the beginning. This is basically how it's done. So you have a full ring of detectors, and then you basically detect the 2 photons, and then you can see from which direction the annihilation has occurred. One of the major developments in this field is actually time-of-flight PET, and it was actually made possible by the fast electronics. So if we have an annihilation which was occurring not in the center of the field of view, one of the photons was reaching the detector much faster than the other photon, and we could actually measure the differences in time. And that would basically mean that if we want to reconstruct the image, we could actually use our information much more efficiently, which basically means we could also boost the sensitivity. So a time-of-flight system, which is now currently the state of the art, has a sensitivity which is 10-fold higher than the previous PET systems. So that also means that we can reduce the injected dose. And this is again an example of such a PET system. You have the full ring here. This is actually the PET system, the inserts that we had to install at our site for simultaneous PET MRI. So this was actually the system that was going into the bore of the MR system. So in terms of isotopes or in terms of radionuclides, what can we actually use? So this is an overview of all the radionuclides, PET radionuclides, also with the different half-lives. And there we can make a distinction between the short-lived isotopes. And these are actually isotopes that are very easy for the labeling because most molecules, they will have a stable variant of these radionuclides. So it's very easy to substitute these. The drawback is that you need an on-site cyclotron because of the short half-life. And also in terms of synthesis, your time is limited. So you need to make sure that your synthesis is done, and there's a bit of a rule of thumb, within 3 times the half-life of the isotope. And so that basically means for carbon-11 that you have a window of 1 hour to do the labeling. Then we have these isotopes with a longer half-life. These can be produced by a generator, also locally, sometimes by a cyclotron, or because of the long half-life, they can also be persisted. But the drawback here is that they need a chelator, so they cannot be substituted into the molecule, which can alter the properties of the molecule. So there you can have different binding properties if you use this type of isotopes. One of the advantages is when you're working with larger molecules like antibodies, that these long-lived isotopes are much more suitable because the kinetics of antibodies are much slower. And then we have a good compromise, that's actually fluorine-18, which has a half-life of about 2 hours. And so this also allows for distribution. And this is actually a map that we have in Belgium. So the red dots are actually the PET centers, so the PET centers. And then the yellow dots are actually the cyclotron centers. And you can see actually that we have a network of cyclotron centers which can basically cover the whole of Belgium and can provide all the PET centers with fluorine-18, which they can use them locally for synthesis, or the traces are synthesized in the PET centers and then they are distributed. This is an overview of all the PET traces that we use in Leuven. So we have a large portfolio, both covering brain, oncology and cardiology. And then this is a short overview of so this is mainly in the context of research. And these are actually the PET traces which are used on a clinical routine. So as Wouter was already mentioned, fluorine glucose, also some traces specific for brain tumors, also some for brain studies, and then also one of the workhorses, the gallium-68 labeled dotatate and the PSMA. And these are actually all reimbursed by the Federal Health Agency in Belgium. And so to give you an overview, why FDG is still considered as the workhorse for oncological PET. And that's because it can be used for different tumor types, as it's demonstrated here. Now that there is a new kit on the block, we are actually now ramping up the use of FAPI, which is actually targeting the tumor microenvironment, and which is actually nicely complementary to FDG, especially for tumor with low FDG avidity. And that's also shown here. And you can also appreciate the lower background activity in case of FOPI. Here it's sometimes difficult to identify small lesions. And with the lower background of FOPI, that's sometimes a bit more straightforward. But then, of course, you can perhaps wonder, you have SPECT, you have PET. Can PET not replace SPECT in case of technetium shortage? And that's actually true for some indications, and especially for bone scan. So this is a bone scan. And this is actually the alternative, the PET alternative. So this is sodium fluoride. And you can see basically that you will get the same information. Even the resolution will be much better with the PET scan. Also, the sensitivity and specificity will be a bit higher, which is demonstrated here. So this is for a standard bone SPECT scan, already high sensitivity and specificity. But then if you're looking at the sodium fluoride scan, you can see that sensitivity and specificity is even a bit higher. And that's especially appropriate if you have specific cancer types, like a renal cell carcinoma with very small metastases. It's sometimes much easier to identify these metastases if you're using PET. But of course, there is already a waiting list for PET procedures, so it's not that easy to replace SPECT by PET. PET is also more expensive. And also, again, the limited availability, we only have a limited number of PET centers, while conventional nuclear medicine is available in also regional hospitals. So the accessibility of PET is much more challenging. So since PET was already coming from a research background, we can actually also use PET to understand the mechanism of specific drugs, and to actually consider PET also as a companion diagnostic for drug development and patient stratification, and then also for diagnostics. I want to show you this slide because pharmaceutical companies are using PET more and more as part of their drug development pipeline, where they actually consider PET in a phase 1 trial in a limited number of subjects to select the suitable candidate. And also to avoid the large development costs of sometimes drug candidates which are not so promising. And so basically they try to involve PET here to save a lot of money actually, and to make these pipelines much more cost effective. Where we can also use it for is actually optimal dosing, because with PET we can have an idea of the target engagement. So this is a baseline scan. This is a PET scan after we have dosed the patients with a specific drug. And you see the reduction in signal because there is a competition between the PET tracer and the drug. And so based on this blocking, we actually can know which dose is needed to achieve a specific percentage of occupancy. And then, of course, also in a clinical setting, a more clinical setting, and this was actually a study done by Boers et al., where they looked at the efficacy of hormonal therapy in patients with metastatic breast cancer. And so staging was done with the FDG PET scan. Also, a biopsy was taken to make sure that these patients have an expression of the estrogen receptor. But then you can still see that there was a big difference in response, but here for this patient, progressive disease. And then they actually included an extra PET scan, which is fast PET. And this is actually a PET scan which can visualize the expression levels of the estrogen receptor. And then you can see here that you have much higher expression levels in this patient, which can explain actually the good response. While in this patient, the expression levels were too low actually for this therapy to be effective. And then one of the most recent developments in positron emission tomography is that we are actually moving now to total body of long axial field of view PET scanners. So this is actually the current field of view. So we can only image the patient of a small portion of the patients. But now we have basically extended this field of view to 1 or 2 meters. And this is a first example of this first total body PET. It actually has an actual field of view of 2 meters. So basically the patient is fully placed into the PET system. So this will boost the sensitivity. This was actually a system which was developed by a Chinese company and was first installed in the US. And this is actually one of the images that was acquired with the system. And you can see here the administration of activity to the venous catheter then the distribution. So first the vascular component and then the distribution throughout the body. And then you see the uptake in the brain, but also like in liver and then finally the excretion through the bladder. So basically there you can have a picture, a snapshot of the whole body in one go. And so with using these long axial field of view PET scanners, we are now boosting the PET sensitivity. For a single organ that doesn't make a lot of difference, we can scan these organs or single organs with a factor of 3 faster. But it has a major difference if we want to scan the total body. And there we can increase the speed with a factor of 40. So that basically means that now if we're using a long axial field of view PET scanner with a field of view of 1 meter, that we can actually be 20 times more efficient. And that we can basically lower the dose to a couple of megabecquerels and have a very fast whole body PET scan. And these systems are actually now becoming commercially available. But of course, at a much higher cost. So this is the current state-of-the-art PET systems. You can count on a budget of 2 million euros. But if you want to go to a PET system with an actual field of view of 1 meter, you actually have to multiply the cost by a factor of 4. So that basically also gives you an idea about the investment cost. But so these systems offer different opportunities actually. We can just use the imaging protocols from the current state-of-the-art scanners, which basically means that we will have an improved image quality. But we can also use this increased sensitivity to actually reduce the dose. And that's especially important in pediatrics, where we can now go to really ultra low dose scanning procedures. On the other hand, we can also image faster, which can increase the throughput and which can also be cost effective. But also we can use these systems to address specific research questions like looking at the brain-gut axis or looking at the brain-heart axis. And then I would like to go finally into therapeutic radiopharmaceuticals. And as mentioned in the beginning of the presentation, also by Wouter, we are now looking at much higher activities, especially if we are using beta emitters. For alpha emitters, we are still using a low dosing. We are also now considering long-lived isotopes. And basically now we want to maximize the dose to the tumor, while we want to minimize the absorbed dose to organ at risks. And there are a lot of names that are currently being used for the use of therapeutic radiopharmaceuticals. I have given an overview here, but basically these cover the same principle. That's the term that is currently being used most frequently and has been considered as the official term. So we have actually different types of particle radiation. We have beta particles, we have alpha particles, and we have Auger electrons. And they have also, and they all have different properties. So the beta particles, they have a longer range, but they have a lower lead. So that's why also we need to administer higher activities for this type of radiation. We then have the alpha particles, which have a really short range, but they have a much higher lead. And then we have the Auger electrons, which are mostly combined with beta particles. And these are actually the isotopes that we are currently using. In clinics, we are still using iodine-131 and also now lutetium-177. In terms of alpha particle radiation, we now have radium-223 and actinium-225. And just want to say that in terms of therapeutic radiopharmaceuticals, we have a long history there. And that now recently also approved by EMA, we have Lutathera, which is basically used for neuroendocrine tumors, and Pluvicto, which is, as Wouter was also mentioning, PSMA labeled with lutetium-177. These are all the therapies based on a fixed scheme. So these are very accessible also. But also there we expect a very strong growth. Only for lutetium-177 PSMA, we expect a global growth of 15%. So that's again questions the supply. I just want to mention shortly also diagnostics, where we actually are combining diagnostic and therapeutic radiopharmaceuticals. There's also an example to illustrate this. This is a targeted therapy where we target the CXCR4 receptor. This is the staging that has been done with the FDG scan. This is then the scan to confirm target expression. And this is then the post-therapy scans to confirm that there is actually a high uptake of lutetium in the tumoral lesions. And then you can see also here that there is a very good response also because the target expression was confirmed. But what should we do for the next years? There is a shift needed from optimizing patient selection to really optimizing the treatment, so that it's not a go or non-go decision at this stage, but that we can really optimize the therapy based on the target expression. We also need to anticipate long-term survival, because you can see the therapeutic radiopharmaceutical is mainly taken up by tumoral tissue. If you significantly reduce this tumoral tissue because of the response, the risk of the healthy organs to be exposed to this therapeutical radiopharmaceutical will increase. So we actually need de-escalating schemes to anticipate response because of the reduced tumor load. And then finally, we also need to reconsider the role of radiopharmaceutical therapy, not only use this as compassionate use, but also perhaps move this from third line to second line, etc. So what are we doing from an E&M perspective? We have an accreditation program to make sure that the PET imaging procedures are done in a harmonized way to ensure image quality. And we also now have an accreditation program being ramped up for Diagnostic Center of Excellence, where we just want to make sure that in these centers, the expertise is present, that also the infrastructure there is present to perform dosimetry and to make sure that we can maximize or that we can optimize patient care. And then finally, a short wrap-up. So for diagnostic radiopharmaceuticals, we still have a high dependency on technetium, and therefore we are also sensitive to shortages. PET and SPECT can be redundant to some extent. And with the new SPECT and PET technology, we can actually work towards reduced activities and scanning times. And in terms of therapeutic radiopharmaceuticals, that is actually the fastest growing field in nuclear medicine, where we now work to personalize the therapy approaches for improving the efficacy and reducing the toxicity. We also, from the E&M, we are trying to maximize the potential of diagnostics, but also there are supply issues at the moment, which are currently limiting the treatment capacity with lutetium-177, and which is actually slowing down the new developments with actinium-225. Okay, and I will leave it there.
Thank you very much, Michael, for bringing physics and technicality between the PET scanners. You also explained the concept of theranostic. Your presentation, you also highlight some issues, so I guess they will be dealt with the next presentation. We can allow for one quick question, and there is also option to ask through online. So if there's something, Cora, do we have questions?
We keep them at the end and when we have the Q&A session.
Okay,
so I suggest that we continue.
Mm-hmm. Question from audience here? No, it means your presentation was crystal clear. Thank you. So now we move to the next speaker. I think there is no need for me to present Sven to this community, but for the sake of the consistency, I will do so. Sven van den Berge, physicist with PhD in nuclear medicine science, is known to you for the 25 years working at the Belgium Nuclear Research Center, SCK-CEN. He is the international technical expert in the nuclear fuel for research reactors. He is the previous director of the Nuclear Material Science Institute at SCK-CEN, which of course include the BR2 reactor and also hot cells. He was responsible for the radioisotope production strategy. Since September last year, he is the Chief Executive Officer of Pantera, which is a joint venture between SCK-CEN and IBA for the production of actinium-225. I like very much your description of the social media. So you wrote about yourself, passionate about the benefits of nuclear technology in medicine and energy. So please share your passion with us. And your presentation will include some outlook on the future demand, supply. Some issues were already raised in the previous presentation, so please try to address them. Thank you.
Well, thank you. That was a very nice introduction, and I'm sure I only merit half of that, but it's actually not even my presentation that I will give to you. I am very honored to say that the presentation actually is made by this man, Dr. Richard Zimmerman, a man that's probably not known to most of you in this community, at least as far as I was part of this community. I never heard about him, but I've met him at about every conference I've gone to since September, since I've changed jobs. This man has a very broad overview of what the industrial situation is in terms of isotope needs, isotope production methods, across the whole spectrum of accelerators, reactors, PET isotopes, SPECT isotopes, therapeutic isotopes. And so I was very honored that when I invited him to come here, he said, I can't. And when I gently asked, could I perhaps give your presentation, he was generous to give his entire slide deck to me. I had to filter a little bit because my time is limited, but let me just say that I think this community needs to hear this message as well. And I want to start actually with a quote of somebody else, one of our colleagues still there today, the reactor radioisotope manager, Bernard Ponsard. Most of you know him. And just to illustrate how quickly this field has become so important, that was just illustrated by the two excellent people before me. Only some 35 years ago, he was derised for being a failed physicist because he wanted to produce isotopes with the BR2 reactor, a reactor that was meant for so much bigger things than isotopes. Today, we know that those isotopes are the main thing that we do and the main social value that we bring. However important nuclear energy still is today, however important we also need to fight for that, medical isotopes really change lives, and I think Dr. Vogel excellently illustrated that. So without further ado, let me go into this, this presentation. There's a few slides I can skip because of the excellent presentations before me. This is one of them. SPECT and PET were introduced, technetium-99 and fluorine-18 were introduced. And I think what we're talking about today is about the therapeutic isotopes. This was what cancer treatment was all about until just a couple of years ago. You had those 5 pillars on which cancer treatment was based. Surgery has been known since ancient times. There is radiotherapy, also quite an ancient technique. Madame Curie was preparing Curie sources for that kind of therapy. Cytotoxic chemotherapy, known to most people that have been in touch with cancer patients. Molecular targeted therapy, a little bit newer, and then certainly the immunotherapy that we've heard about. Well, today I believe that everybody will acknowledge that we can add a 6th pillar, which is linked to this targeted radiotheranostics. And this is really happening on a daily basis. This is really moving forward on a daily basis, and it is the challenge of this community of research reactors to be able to follow the speed at which these things are evolving. And yeah, I've changed a little bit from research to more of the economic side. So graphs are starting to show axes that are in dollars instead of whatever, barns or something. But it illustrates something. The theranostics and especially the radiotherapeutic world is expected to grow at a compound annual growth rate of 39.1%. And this is a graph from the reports that Dr. Zimmerman participates in preparing, him and his company. And this is a graph that was made in 2019. Actually, the most recent one is this one. It's from the most recent report, 2022. It may not look as nice, but it illustrates that nothing has changed since then. That growth is still there, and the speed at which things are growing, yeah, it's difficult to predict. You see the lower or the higher growth, but we're still on that curve, and so those 39–40% per year are still what we expect as a growth on the radiotheranostics side. So let's look at what isotopes and radionuclides are expected to be needed in the market between now and, let's say, 2032. We have the SPECT isotopes, where I think everybody agrees technetium-99 will stay the biggest workhorse. There's so much research behind it, so many molecules available to which it can be attached. There's a load of SPECT scanners throughout the world that are even optimized, as we heard, for technetium-99. So it is there to stay. Certainly iodine 123 is an isotope that is also quite frequently used, but the biggest workhorse there is definitely technetium. You've heard about the excellent evolutions in PET scanning, the better resolution that they have, but also the higher cost and the lesser availability. I'm sure over the next couple of years, and this is a statement also made by Dr. Zimmerman, PET will become more important. It will become more mainstream, and some of the SPECT scans will definitely move into a PET scan. But it all will be at the same time that countries that today do not have that broad access yet to PET or even SPECT will start moving into SPECT. So probably the technetium-99 will serve other countries that are moving into that nuclear medicine diagnostics. But today we're here to talk about therapeutics, and I think it would take me too long to tell you the story about all of those isotopes. So I'll pick out two of them. There's the lutetium-177, which is for this community the most important one. It's the one that is currently in its high growth rate. And of course, given my new role in the new company, I feel obliged to at least tell you a little bit something about actinium-225. So what does that economic image look like? How many compounds are there actually today on the market? How many medical products are there on the market that are based on radioisotopes? And here I'm not just talking about the targeted radiotherapeutics, we're also talking about some of the older therapies, such as the ones that are based on iodine-131. There are today about 32 medical pharmaceuticals that are available on the market today. That are based on those radioisotopes. But by far, this doesn't indicate, this only indicates the number of them. It doesn't indicate how much of them are actually used. And by far, the two of the three, or the full three of the lutetium-177 based compounds are the ones that are in high growth. We've heard about Pluvicto, we've heard about Lutathera. Lutathera is the neuroendocrine tumor treating dotatate-based lutetium-177 compound, and Pluvicto is for prostate cancer, the PSMA-based, the one that Dr. Vogel so eloquently talked about, and his patient was treated with. So let me show you where we're heading from this. 32 compounds, and today there are over 150 in different phases of clinical trials. Now, not all of those will come onto the market, but you can imagine that a significant fraction, and especially because actually the success rate in radiopharmaceuticals is higher than in other pharmaceuticals because of all the tracing capabilities that we've had, there are over 150 in clinical trials today. As you can see, there's a lot of it on prostate cancer. You've heard why. There is a big market for it. Again, economics does matter. But on the other side, there are a few more general ones. You see the FAPI column already there. It is not highly populated, but it is growing at a quick rate. And you also see that fourth column there with a lot of compounds that have different molecules attached to it. And every day we hear about new molecules coming up, targeting different aspects of cancer cells and different cancer types. So just for the lutetium-177 alone, you see that there are 55 compounds that are currently being researched. And all of those treat a different, not all of those treat a different indication for cancer. Some of them are all going after that PSMA, but there are quite a number of them that are in different clinical settings usable for different patient types and patient physiologies. You have the alpha emitters below that, which is considered to be somewhat of the next phase where the beta emitters might fail or might not give enough of an energy deposition into the tumor, or where you might have the need for a more local treatment because the alphas have a shorter range, of course, than the betas, and that's where the alpha molecules come in. So the excellent question that was just asked by Steven was, so what are we preparing for? Because you can talk about compounds, but how many patients are we preparing for? What doses are it? And so what kind of volumes do we need to prepare for? And this is the center part of the message. For lutetium-177, a patient will get about 2 to 6, on average 3 doses of each about 200 millicuries, which means that the production needs to be about 400 millicuries and of a radiation dose. The average amount per patient is therefore 1.2 curies. So we can start calculating. we look at the number of operating reactors today, and I'm really sorry if your reactor is not there. We can blame it on Richard. I won't tell him. But you see that there is quite a list there, and there's about, let's say, 6 major reactors that are currently in the production of lutetium-177. Richard is an optimistic person, so he's predicting that by 2032 we might have 9 of those. I'm not sure about that number. That's why I made the box red. Dr. Zimmerman had it blue, but I'm still considering this as something that we really need to take into account if we want to reach those 9 reactors by 2032. Each of those reactors, how many targets can they irradiate? That's the hardest part for Dr. Zimmerman to figure out, and that these estimates, I've talked to him about this, and I think we should try to provide more information, because this is really what it's all about. How many targets can we put in each of our reactors, and how efficiently can we do it? The estimate that Richard has made is between 5 to 10 capsules, 5 to 10 positions in a reactor that we can use, with each of those positions containing between 4 and 6 targets, little ampoules with a hardly visible speck of ytterbium-176 to be transformed partially into lutetium-177. So about 1 to 2 grams of ytterbium. The number of capsules per reactor, as I said, is the number with the highest uncertainty. But let's say we have 5 to 10 ampoules with 5 to 10 capsules per reactor with 6 ampoules. So today, 5 times 6, maybe tomorrow 10 times 6 positions times ampoules per reactor. So we go on and do this kind of calculation. We are considering that for the future, non-carrier added lutetium-177, which is the pure form, which doesn't contain the long-lived lutetium-177 metastable, is going to be the only one used in the future. And of course but that's time for a different discussion, and I'm sure Remik is well aware of it as well. The access to ytterbium-176 is a major item to be discussed, because today the world depends on the Russian isotope suppliers. So we have the number of operating reactors multiplied by the number of targets we can irradiate per reactor times the irradiation frequency. So given the typical duration of irradiation, 1 to 2 weeks, today more and more 7 days irradiations are being used, with an average operating number of operating weeks per reactor of about 30 weeks, which is already pushing it. I mean, that's a large amount for a reactor. So we multiply it by 30. And finally, what are the yields that we can get from our reactors? Of course, there are some differences, but most reactors are able to irradiate in a very similar radiation environment. So we're going to say that per gram of ytterbium-176, we have about a yield of 25 curies and a loading of 1.5 grams, so 1.5 times 25. In the end, that means that today we are roughly capable, according to this broad estimate, and of course you're welcome to make your own, and I'm happy to talk to you about it, between 200 and maybe towards the future, in an optimistic setting, 600,000 curies per year. Now, what does that mean? What are the needs? Well, there's about 0.4 curies that we need per patient. There are about 3 doses per patient, and there are about 100,000 patients in a disease pool that can be targeted for some of the bigger indications, and I'm sure our clinical experts can comment on those. Maybe it's 200,000, 300,000 for some, maybe it's 50, 20,000 for others, but on average, let's take 100,000 patients. This essentially means that our entire reactor capacity is limited to 500,000 patients. And I can look again at Wouter, that's not what we need. We need quite a bit more. So especially if those compounds keep coming, if the number of medical pharmaceuticals that are available today, that will be available tomorrow, are going to be growing, the number of reactors simply isn't sufficient. So what can we do? What are the different types of things that we need to consider? Well, the access to the ytterbium-176 is one of them. As I said, let's keep it for another day. There are a few new sources of the ytterbium-176 that are coming up. And so the expectation, once again, Richard is an optimistic guy, is that by 2025, this will be solved. I'm really hopeful that it will be, and there are some good indications for that. Then the price of the ytterbium-176 may drop, but there's presently no hint that the price of lutetium-177 will drop. And this is where I share my feeling with you. It shouldn't. We should not allow that price to become under pressure and to become a market like we have for the Moly-99, where the production costs are not covered entirely by the price that we can ask as reactors, as producers for this isotope. The number of 177 lutetium labeled molecules is going to increase very rapidly. Yes, the neuroendocrine tumor and prostate cancer areas are quite crowded with new molecules, so not all of those will eventually lead to a need for 100,000 patients, but there are definitely a lot of other indications that are being studied today. But the production capacity limitation is the most important and the most crucial limitation that we have. Presently, there are some alternatives being explored. I guess we all know that. The CANDU reactors in Canada are being one on the list of the reactors being explored as production reactors. There is the SHINE, and there are other accelerator-based productions that are being studied. Indirectly, this will positively impact the terbium-161, which is the next level isotope, which might be a replacer for the lutetium-177. It's not going to be so much an addition to, but much more of a replacement. And of course, the Moly-99 as well. But today, what we have as reactors, and this is my sentiment, I'm sharing it with you. It's also not Richard's statement, and he's very interested in discussing it further after seeing this in the presentation, is that we have a lot of non-carrier added lutetium-177 producers, a lot of people that come to our reactors to irradiate their ytterbium-176, but we only put one client per capsule, per position in the reactor. And that means all of those small clients quickly occupy all of the positions, which is not an optimal use of the positions that we have in the reactor. So the production capacity today is not very efficiently used. And this is where my messages come in. These are not Richard's words, these are my words. On the number of European research reactors, we have today in Europe, and this is where we are today, 2 large and 4 smaller producers, and the post-2035 HFR might be replaced by Pallas. That's really what I hope. I congratulate the Dutch government on their choice there. JHR is expected to be online. BR2, there are uncertainties post-2036. Even today, we have to obtain, BR2 has to obtain its continuation after 2026. And the RHF, to some extent, there are some uncertainties about that. There is no way with this kind of setting that this reactor community can follow the demand increase. There's about 10 to 15 years to build a research reactor, and financing and justifying a research reactor construction and operation is certainly not an easy thing. And the Dutch government knows very well how hard it is. So that is a statement that I make. I give it to you, and I give it to our decision makers because you cannot wait very much longer to be able to follow the demand increase that I've just predicted there. Research reactor capacity and the impact of the large amount of lutetium-177 clients, it's an enormously rapidly changing market. The evolution that I was able to catch when I was still at SEK until about a year ago was already going like crazy, and our reactor manager here today will acknowledge that it's hard to follow how quickly things are going. Previously, fission moly was what we did, and the rest of the isotopes were on the side. Now today, that evolution is definitely going towards the therapeutic isotopes. High flux irradiation positions in reactors are being increased to the maximum extent possible, but are often poorly used, as I said. And therefore, I give an example of the BR2. Sometimes only 10 to 15% of the theoretical capacity is actually used, which means a loss of revenues for those reactors, because those positions could make them more money. And that means that there's a loss of the sustainability as well. There's a need for a consolidation or a change of the supply model. And I know that some of these statements are probably utopic, but I'm a utopic guy. We discussed that, Jeff, right? So some of these things might be solved through a regulation, especially because of the ytterbium-176 stock being so crucial in this, to have a European stock, to have a collaboration between the lutetium-177 providers and have them share irradiation capacity, or we just have to wait for economics to do its job and wait for a market consolidation. But the timing of that is uncertain, of course. Two more messages: the impact of alternative production methods. They are welcome to the market very much, especially also by politicians, as reliefs for research reactor needs. But I want to warn about the high risk, and again, this is my statement. There is still an unproven reliability and unproven sustainability for those technologies. I am not against it. I'm a technology-loving person. I'm a physicist, so I love them. But once we realize the risk, it may be too late to return to research reactors. Also, their business model is unproven at the moment. I hope they will make it, and we will need them. But the marketing strategies do differ from those of research reactors that are often, almost always, government supported, if not simply always government supported. They have a private equity model, which may change the economics of the whole thing quite drastically. And if we look at the options for Europe, we have two CANDUs in Europe and Romania, and there are very significant differences in licensing requirements and government support compared to the US, who has gone all out on the domestic supply. So Europe will have to do things differently than they are done in the US. And when talking about the pricing, as I said, we should not allow the lutetium-177 price to drop because at some point we will simply be in the same situation as with the Moly-99 market once again. And therefore, full cost recovery should be our basis, but the value of what we're delivering, we should be aware of that. We shouldn't be greedy and trying to make millions of dollars in profit, but on the other hand, we should be aware of the value that we're creating for people that are in some very dire conditions themselves. And so that value-based compensation is something that we should explore. My proposal there is about 10% of the treatment cost should be the radioisotope, whereas today we all know that it's 1%, 2%, 3%, and even the lutetium-177 is under pressure to go lower and lower and lower. Why? Because we are not at the table when reimbursement is a subject. It's pharma that's at the table. And therefore, the reimbursement of the radioisotope might be separated from the reimbursement of the treatment and the pharmaceutical itself, which allows that reimbursement of the radioisotope to be discussed directly by the producers. And that is something that is already the case, at least the separation in Belgium. So I would invite the rest of Europe and the rest of the world to follow that example. And I think our government will be happy. I'm not seeing my government representative here, but would be happy to support. So I will skip the alphas, although it is what I'm doing today. I'll be happy to talk to you about it for the rest of the week, but I'm running out of time, and the main message was about the reactors, and the alphas are accelerator-based productions. So I'll be happy to talk to you about it and leave you with a final picture of the same kind as you've seen before, but the effect of actinium PSMA this time in a patient that was treated in 2014, and after only 4 injections with actinium PSMA, you see the enormous difference in the cancer there in this patient. So actinium-225, the promise for the future, yes, but lutetium, terbium, and the reactor community here around in this room is going to have a very high and positive impact on the nuclear medicine in general and on the cancer patients. Thank you for your attention.
Thank you, Sven, for your very profound and comprehensive overview of the market, especially your insight into these two theranostic superstars, lutetium and actinium. I hope that during the question and answer, you can return to your Pantera business more. We can allow, I guess, for one quick question from audience and from the online participants, if there is something.
Well, then I have a question online. I have to check again. I'm not sure, Sven, if you can answer it, but it was during your presentation. Except from cancer treatment, are there other medical uses of nuclear medicine? I think
I think they've been very well introduced by Wouter and the speakers before me, where indeed radioisotopes are being used to label, let's say, molecules that we would inject without having a capability to see from the outside how they go about their business in the human body. So if we put a radioisotope inside that, it has the same chemistry. That molecule does exactly the same thing. But the thing is, we can now follow it from the outside. And so I thought I hadn't seen that before, but apparently even chemotherapy, which was usually injected and then said, yeah, we hope it works and we'll see you in 3 weeks and then we'll talk again. Now it can actually be traced and seen how effectively it is taken up by the tumor because of those radioisotopes. So that's one thing, but there are many others as well. And then you have the industrial applications of radioisotopes with gamma X-raying, not X-raying, but gamma imaging of welds and things like that. So yes, there are definitely a lot of applications outside of that.
Thank you, Sven.
Sven, one more question from the bottom of the meeting room.
So I don't really share Richard's optimism regarding the number of research reactors in the future. So the alternative to me seems power reactors. Potentially not the ones that we currently have, but not everybody in this world seems to adopt the German approach to nuclear power, but others build new ones. And if you start fitting these new ones from the very beginning for isotope production, would that be a potential alternative?
Well, that's a good question. And of course, you have an enormous fleet of power reactors, but there's a few things, and I won't be long. I will try not to be long. One is the flux. Only CANDU reactors have the amount of neutron flux that is required to effectively produce. Can you still produce? Yeah, sure. You can do everything less efficiently and then make it, of course, more costly. But in the end, you will have some production. Secondly, and this is for me the biggest one, I am still surprised today that even CANDU operators that have as a primary objective the production of electricity would allow to take the additional risk, because there is a risk involved to allowing this additional application of your reactor. What if you start depending on those power reactors to produce your isotopes, and you say we don't need the others anymore, and then one of them scrams because of the isotope production, and the electricity producer says, hey, we're not having this. Do you know what this costs per day? That would be one of the threats that I see in the whole CANDU story. And so I'm really hopeful that they will be there, because, as I said, we will need all of it. It's not, we shouldn't feel threatened by them. But flux-wise, I don't see PWRs immediately going there. There's also no loading and unloading, even if you would do it with more modern reactors. But even for any power reactor, having that additional application, having that additional risk seems to me like something that we should be careful with.
Okay, thank you very much. So we move to the last expert. Now I see that we basically failed the gender balance principle. So Charlotte Rosenbaum, she is the master degree in physics and medicine. She also got PhD in radiology and nuclear medicine at Utrecht University, Netherlands. She has a 6 years experience in the radiology and nuclear medicine, and also 10 years experience in research on ionizing radiation. Currently, she is at the program coordination of the Department of Radiation Research at the Dutch National Institute of Public Health and Environment. And there she is responsible for setting up and the execution of the research program. So in this last but not least presentation, Charlotte will speak about the different production methods and try to describe what capacities are needed to come up with the line with what is needed in the future. Thank you.
Thank you for the introduction, and thank you very much for giving me the opportunity to share our latest report on the production of and supply of medical isotopes. So I work for the Dutch National Institute for Public Health and the Environment, and we do research mainly for our ministry, for example, for the Ministry of Public Health. And for one of their policy makers, we published a report in 2020 on the supply guarantees for medical isotopes. So I will take you through the main parts of this report. It will include the current production of medical isotopes and this will be on mainly on the irradiation facilities, being the reactors and the new alternatives, the accelerators. So the out of scope for this report were cyclotrons. Then we will look at developments in radionuclide use, both for diagnostic purposes, but also for therapeutic use. And then we take a look into the future of the production of medical isotopes, as we have also already heard from the previous speakers, that these are important issues to discuss. So even though this presentation will be mainly about accelerators or reactors for the irradiation supply, we must not forget that the entire supply chain is important. So if you want to have a reliable and guaranteed supply from the raw material to the patient in the hospital, you need each and every factor in this chain. So it's not just the raw or enriched materials, it's not just the irradiation facilities, but you also need the processing facilities, both the radiochemical part and radiopharmaceuticals. And then you need a reliable transport to hospitals and patients. So let's first look at the current supply chain for molybdenum-99. This is an image from 2016, reported by Technopolis. And you can see here on the left, it starts with the raw materials. And then in the middle, in the blue pentagons, are the irradiation facilities. And next to that, the molybdenum suppliers. And then to the right, there are the technetium generator suppliers and the end users. Now, this is an image from 2016. So I must say the lowest part where the NRU is still mentioned, that facility has permanently shut down in 2018. So we are left with 6 blue pentagons here. The top 4 are in Europe. So those are the European reactors. And then there's one large producing facility, irradiation facility in South Africa, and the Opal generator in Australia. Then for the molybdenum suppliers, there's 2 of them in Europe, the IRE in Belgium and Mellencrout in Petten in Netherlands. And then 2 large ones, one in South Africa and the other is located near the Opal generator. Now, if you look at the end users, you will see that large part, 55%, is North America, but none of the previously mentioned initiatives are based there, and they have noted that too. So there have been radionuclide shortages in the past. We can mention the 9/11 attacks on the Twin Towers that caused the airspace to be closed. And when you rely on overseas supply of your radionuclides, this quickly becomes a problem. Now, there's in the period 2008 to 2010 were coinciding planned and unfortunately unplanned shutdowns, in this case from the HFR, which caused the molybdenum shortages. Now, in the spring of 2010, there was a large volcano eruption in Iceland, the Eyjafjallajökull volcano. This again limited air traffic and then caused radionuclide shortages. And then March 2020, COVID-19 hit. So, for example, USA has started several plans to become self-sufficient and have more domestic molybdenum supply. You can see in this image some of their initiatives in this for this issue. This is an image from 2016 publication. The bottom 2 are listed as suspended, and I have not found any recent information on that. The top one, the GA Nordion, is a collaboration with MER reactor. I haven't found any recent information about that, but we will look at the North Star and Shine facilities in some next slides. You can see that this is not only irradiating of enriched uranium targets, but also some of these facilities will irradiate molybdenum targets. Now, the largest production for medical isotopes currently are these 8 reactors. So it's the 6 that we have also already seen in the previous slide. And then also 2 smaller research reactors, the FRM2 in Germany and ILL in France. You can see here that a large number of these reactors are actually were already constructed in the 1950s, 1960s. It doesn't necessarily mean that they will give out anytime soon, but it does mean that per operational day, there's more maintenance required. So per operational year, you will have more maintenance cycles and less production. So the two largest in this image are the HFR in the Netherlands and BR2 in Belgium. And for example, for the molybdenum supply, they are producing about 60% of the global demand. Now let's look into the future developments in radionuclide use. We have heard from the previous speakers also that we can expect much larger quantities of use than we are seeing right now. This is an image taken from the MedRace Intel report 2022 with projected developments up until 2027. The bottom bar for the yellow bottom bar is the technetium. So this is obviously the workhorse for nuclear medicine, and it is here to stay, as we've also heard Sven. There is a growth expected. So for the current market, it is approximately 0.5% per year, but for the developing market, this can be up to 5 or maybe even 8% per year. So the brown bars are the PET tracers, and we do expect an increase in that, but most of them are produced in cyclotrons. Spec tracers are relatively stable, demand is projected. And then for the radiotherapeutics, as we have heard from the other speakers, we do expect a large increase in use of these. So it has started some years ago with radium-225, that was mainly for bone metastasis. And then Lutathera came up in 2018, and now we are looking at other combinations with lutetium-177 and also actinium. So we've heard a lot about lutetium-177 already and the actinium, but there are others, for example, maybe scandium-47. This is in research for treatment of liver metastasis. Another big one probably will be terbium, which has 4 isotopes with interesting decay properties and characteristics, both for diagnostic and for therapeutic use. And there are maybe many others, and these will be probably in the coming years researched and tested in clinical practice. So let's look at the projected demand and supply for molybdenum-99. This is an image taken from NIA report in 2019, and this is their scenario for the currently operating irradiation and processing capacities. So the red line is their projected demand in growth, and there is a green line that is plus 35% for outage reserve capacity. So you would love to stay over the green line. Now the data points in 2008 here are real data points, and from 2019 it's a projection. And 2018 you will see a dip in the pink line, which is the processing capacity, and this was due to an unexpected loss of supply from the NTP facility in South Africa, which came online again in 2019. And from there on, you can see that projected is the processing capacity will be over, and by the time we hit 2024, just barely over the 35% outage reserve capacity that NIA predicts will be necessary. Interestingly enough, you see that the irradiation capacity is over the pink line on all data points in all projections. So we do see some fluctuations. This is the normal projected planned stops for the radiation facilities for maintenance. Now, the NIA has also projected in another scenario, and in this one, it's not only the current irradiation and processing capacities, but also the new initiatives that are coming to the market. So I will show you a list and a short overview of some of those in some of the next slides. But here you can see what NIA expects from that. They have, in this scenario, taken the capacity for production and irradiation for new initiatives that have not yet proven themselves at about 50%, as to be more realistic in their view. And also they have, in this graph, shown a 2-year delay, contrary to what facilities or projects themselves will announce for planned starting dates of production, because history has learned that most of these large projects will have some or many years delay in eventual start of production. So this is a graph taken from the 2019 report. I do know that NIA is currently working on a 2022 report. It is under review, and I have a feeling it will be published any time now, and it will give new insights into the demand and capacity projections for molybdenum, covering the 2022-2027 period. So I'm very interested to see their new graphs. Now, looking at the therapeutic radionuclides, we have already heard many things about that. This study by JRC, a report from 2021. They have asked multiple experts from European countries what their expectation for the demand will be in the coming years for these radionuclides. So in red are the bars where experts have said they expect a decrease or a large decrease even in the use of this radionuclide. And then in light and dark green, they expect an increase. So not very surprising, the top two is lutetium-177 and actinium. More than 80% of experts say they expect an increase or even large increase. Then there's thorium and holmium-166. Again, 50% of experts say they expect an increase, and also a large proportion of the experts in the gray bar expect this to be stable. And further down the line and at the bottom are some radionuclides that may be phased out in view of these experts. So what kind of radiation facilities will be producing then all of these high demand isotopes? So this report states this graph within red the current irradiation facilities that are capable or even already producing these radioisotopes. It's the Maria reactor in Poland and the BR2 in Belgium, the reactor in Czech Republic and the Dutch reactor, and then the Hungarian facility. It's not clear how long most of these reactors will keep producing. So in gray, there are some new initiatives added to this graph, although it's for those initiatives difficult to say when they will start producing. So in our 2020 report, we created this overview of the new initiatives that have announced that they will come to the market. And these are sorted from top to bottom, from the ones that say they will start first to the ones at the bottom that have, at least to me, unknown starting dates. You can see and appreciate that a lot of the initiatives are based in the USA. So at least the top two, the Nioweave and the North Star, and also there's a Northwest production facility in this overview. And some of these facilities, so this is this table is from 2020. You can see that the top one says they are already starting the test productions. North Star said they would plan production start in 2021. These are accelerator type irradiation facilities, and there are also some reactors or research reactor facilities. So now this was the in our 2020 report, but now we are 3 years into the future. So I checked to see if there are any changes. And this is what has changed in 3 years. So NioWeave indeed was built, but actually this is just a prototype, and I do not have any information of larger scale production of molybdenum, let alone the other isotopes that they are expected or planning to produce. And actually this is an accelerator type, but more precise, this is an accelerator-driven subcritical reactor. Now the North Star facility has been constructed and all equipment is installed. Last time I checked, they were not planning to start in 2021, but it's now more towards the end of this year or the beginning of next year. Then Shine has 2 separate locations also for an accelerator-driven subcritical reactor. The one in USA, they have been building or are building since 2019, and the current predicted production start is 2023, is their own announcement. In Europe, so far there is only an option to purchase a building site, and no planned production start is known, to me at least. The Bruce Power generator is producing, as far as I know, molybdenum-99 and lutetium. This was a reactor that was already there, so this was a refurbishing. So maybe that's why they could make their own announced time path. The Jules Horowitz reactor in France, it has been under construction since 2009. Last I know is that in December 2022, they have put in a final module. They say they're starting production this year. I haven't heard any from it, so I'm not sure when they will. Then there was the Northwest production facility in the USA. Their website has not been updated very regularly, and ultimately I found the cancellation of the building permit saying that there was nothing built and nothing produced, so I crossed it off this list. Also crossed off the list is unfortunately the SMART initiative in Belgium. Just last year they announced that they were able to produce molybdenum, but only a few weeks ago the project was cancelled. And then there are initiatives further in the future. The MIRA in Belgium is planning to start production in 2036, also an accelerator-driven subcritical reactor. Pallas reactor in the Netherlands has at this point completed licensing and the tender for construction, and optimistically they are saying production will start in 2030. And the bottom 2 I have no new information on. So in conclusion, we have heard also from the other speakers that there is a growing demand predicted. This is both for the diagnostic and absolutely for therapeutic radionuclides. But the rise in supply from irradiation facilities seems not yet guaranteed. And not much has changed over the past years in the operational radiation facilities, as I've shown in the last overview. So I would like to end this presentation with something to think about. It is a Chinese proverb, and it says, the best time to plant a tree was 20 years ago. The second best time is now. Thank you for your attention.
Thank you, Charlotte, for your very nice overview and also putting Europe in the broader perspective to show that we have a very strong position, but we are not isolated island. And especially this, say, spaghetti graph with many interconnections shows how we are all connected, and also explain that whatever happens in one supply chain player propagate immediately to the end. Any other questions to Charlotte? If not, to gain the time, before I give the floor to Cora to guide you through the question and answer session, question from me, because you all experts are from the, say, different corners, sides of the supply chain. If I ask you to list 2, 3, the main challenges, obstacles for the future development of nuclear medicine in Europe, what you will tell? Rapid fire session, so less than 30 seconds. We start this time with the ladies. Charlotte, please.
Is it? Yeah, that's on. What is the greatest obstacle? Okay, I will take the easiest one. It's money. So it's money to put up facilities. It's what Sven has already said, paying the price. Who is paying the price for this? I hope it will not be the patient paying the price.
Okay, thank you. Sven?
I would say, yeah, no, money makes the world go round, absolutely. But I do believe that the value that's created by the radioisotopes is something that should be reimbursed better. And so having an improved reimbursement policy in which that radioisotope is separated is, for me, the biggest challenge.
Okay, thank you. Michael?
Yeah, so to mention something different than money, it's perhaps also to focus a bit on training, because it's very important to have the experts ready, because we're quite ambitious in terms of diagnostics. And I think we have the infrastructure in place there, but also we need to really be careful that we also train all the people to be expert in this.
Okay, and we back to medicine, Wouter.
I think it's uncertainties. When I started nuclear medicine 20 years ago, we were using technetium and iodine. That's hardly used today in my department. It's all fluor, gallium, and lutetium. I would not have predicted that 20 years ago. So for me, it's very hard to predict which medical isotopes I need 20 years from now, for which diseases and how they are produced. And this uncertainty is, I think, limiting for investments and whatever.
Okay, thank you very much. So we have now 15 minutes for the question and answer. So I will give floor to Cora to guide you through this session.
Yes, thank you. Well, you have heard 4 fantastic presentations. It gives us a good overview of the market and the whole chain. Are there any questions here in the room? Yes.
Hello. Yeah. Okay, my name is Jorgelina. I am from INVAP. I am currently working for the Palace project. And my question is on whether you believe that regulatory bodies or licensing issues might be also a setback at the time of, promoting or leading to more reactors for the production of radioisotopes.
Charlotte?
Maybe not so much the licensing itself, because I think there are rules for this and frameworks. But from my perspective, I think the people who are, for example, governments who are involved in this, they may have an information bias, or may not have enough information, and we will need to provide that from the field, for example. So I think it's very important that the field and end users speak up and let the decision makers and governments know what is necessary. So if they are heard, I think that would be absolutely imperative for the decision makers and policy makers and licensing to get a head start.
I can perhaps add to that also it's quite important to generate evidence data, so that we can really support our claims also in terms of reimbursements. And that's why I think also like these multi-center trials and the collaboration between different therapeutic centers, that's quite important actually, to build up the evidence and to at some point file for reimbursement.
I can add one thing. It's a little bit on the periphery, and it's going to make some people in the room nervous, I'm sure. One thing that we've seen in these outages lately and with the shortages is that there is clearly a body that is trying to make sure that the reactors operate safely. There is in every country, there are those authorities, and they make sure that the operator behaves correctly, and that if there is an issue with the reactor, that it is shut down and the repairs are affected. It's not up to them to weigh the risk of starting the reactor or the risk of not having the supply available. It's not up to the reactor operator either, but today I don't know if any body is there to make that call, to say what is now going to have the biggest impact on the world, not having those patients being supplied with their radioisotopes or starting the reactor and dealing with this issue. There's just nobody there that makes that call.
Okay, thank you. I have a question online, and that's in line with the previous question. Is there sufficient infrastructure in all European countries for them to apply these effective methods of diagnosis? And how can we ensure that all patients have access to this type of advanced medicine?
That's a very good question, because the supply chain from the reactor to reaching the patient, as was already shown, is very long, and it involves many technical steps like purification, quality control, labeling, etc. But it also involves a lot of regulations, certification, quality in GMP, medication grade levels. And those regulations are really different in different countries, and they can even be different between centers. So that there can be obstacles in some countries or centers of the same medical isotopes reaching the patient. And there's a lot to be learned there in some countries.
And perhaps I can add on to that, so you have the radionuclide on one hand, but you also have, of course, the therapeutic or radiopharmaceutical. So that at some point needs to be synthesized. And so from an E&M point of view, we still try to support the in-house production of radiopharmaceuticals, because we think that this distributed system will assure accessibility much higher, which will be much higher for patients instead of some centralized production unit. So that's also something that we would like to actively support. And that basically means that we need to look at legislation, also the legislation on radiopharmaceuticals, which is now currently under revision. So we need to make sure that these revisions are in line with this policy.
Thank you. Question from the room?
Thank you, Frank de Koning. We have seen lists of new projects with estimates for dates when isotopes will be produced. I've seen, for example, I'll give just one typical example, Jules Horowitz is still mentioned 2023 in your list, okay? Now, my question is the following. There is a big difference between announced dates and real dates. Is it due to finances, which was mentioned? I didn't hear anything about changing regulations, and I didn't hear anything about technological problems. So why does it take 10, maybe some 20 years later than expected before a reactor starts producing?
Yes, this is a good question. Also one I have when searching for these numbers. So this is quite obscure to find your way through all of these announcements and all of these collaborations, who is producing what, and actually where are they producing this. So there are projects that say they produce lutetium currently with their accelerator, and then when you look through all of the data and more reports and more websites and more news feeds, it turns out it's actually collaboration with a reactor. So this is all interconnected, and there's all kinds of collaborations. Now the new initiatives, the accelerator-based types, I think in part this is a technological problem. So this is not a proven technology yet. And so it's an optimistic announcement to say we are starting production then and then. This is also, of course, connected to money, because one project will say we are starting then, hoping another project won't start because they're thinking, okay, once they are producing, then we cannot sell our product. So I understand this is corporate and commercial interests. But I think some part is money, some part is technological problems, some part is not being able, for example, to get the cooling of your targets right for these new accelerator-based initiatives. And then the part for reactor build, I'm not sure. I think it's very large projects. Jules Horowitz has been, the build has been going on for a long time. I don't know what the new projections are. I think 2023 is highly optimistic. Maybe Sven, would you like to add something to this?
I'm going to let the people from Jules Horowitz in the room speak for that, and I'm sure there are quite a number around. But one of the things that we should look at is the difference in the model of selling a cyclotron, which is becoming quite cheap today. We will never get there with a reactor, but at least making sure that there is an economic reason and an economic basis to build a reactor. And the Netherlands have done the exercise, and today the answer is there is none. I mean, there is no economic basis to build a reactor for radioisotopes, while this contrasts enormously with the value that they create. So I'm sure something can be done about that. And once you reach that point where it becomes economically viable to make a business case to build a reactor to produce medical isotopes, you will get a lot simpler reactors that are actually there for smaller productions. And I think that's a better way to go. But of course, in the end, it's still governments that need to take the decision to allow this in their country. And well, we've heard about the German way of the world today and where they are heading. It's not a straightforward choice to allow a research reactor in your country. So if we're going to stay with this system where a few countries operate a research reactor and produce isotopes for the rest of the world, we better make sure that they don't continuously have to realize that they are putting their taxpayers' money into it, because that's not a sustainable system.
Thank you. I saw another question in front. Oh, okay. Then
Hi, Maciej Lipka, Maria Reactor. I've got pretty provoking question, because we've got a couple of scenarios by OECD NIA, by GRC, by DGNR. In a couple of those scenarios, we see the slow decline of producing capacity with rapid increase of the demand. And some of them we see rapid collapse in 2040s, 2050s. So what do you think? Will it be slow decrease or rapid collapse?
I think my main answer is that we've seen how fast a reactor can be shut down. And I think from the Jules Horowitz example, and I don't want to bash on them, absolutely not, we see how long it can take to put one into operation. And yeah, I mean, if something happens to one of those research reactors, then it's going to be a very steep decline, an instantaneous shutdown. If nothing happens to them, well, it's kind of still that way, because they will have a moment where the authorities will say, well, this is the end of your life. You either go to a replacement, or you stop operation, or you do this or that. We're pushing the last bit of capability and life out of those facilities. And we're happy to be able to work with the authorities to be as good as possible on that. But there is an end date there. And if we don't prepare for it, it's going to be faster. The announcement of the end date, if we get one, is still not going to allow a construction of a new reactor. So that's.
okay. I have online one question, and several people are asking. It's for you, Wouter. I don't know if you could answer it but because they ask, can you prioritize cancers for which new radiopharmaceutical treatment should be developed? Which one would you choose?
And that's a really difficult one, because every patient has the same value to me. But it's true that there is a much larger benefit of a discovery if it applies to a large patient group in a high demand. So we've seen this by switching from neuroendocrine tumors
very small population, to prostate cancer, a huge population. And this really gave a big boost to the use of medical isotopes and expanding knowledge, etc. So if I may pick another one, I would, for example, love to treat patients with breast cancer or lung cancer, colorectal, the big four. And because we need volume to show good data that it works and for which patients it works.
Thank you. I have to look at the time.
Hi there. Quick question. I don't fully understand how it becomes a more frontline treatment. It seems to be a last-ditch effort that we use radioisotopes for in therapy. And how do we move it ahead, and what's the factors that move it ahead?
Yeah, that's a good question. I think every new experimental treatment starts as a last resort end-of-life treatment. We've seen this, for example, with immunotherapy. But once you can show it works, it starts moving forward in the treatment. So immunotherapy is now used as a neoadjuvant treatment, as a primary treatment, even before surgery. And it shows value. It took about 10 years to move from the last phase of life to the first thing after diagnosis. And I see the same movement coming for medical isotopes. There's already studies that lutetium PSMA can have a benefit for patients in the first occurring event of metastatic disease, even when still hormone sensitive. When you have other treatments available, it also works. But those studies are just starting now, but I think it will come, sure.
And, can I add to that, or maybe it's a question, that right now this is mainly coming from nuclear medicine department, and you will need to get your medical oncologist on board, and they are their shop is chemotherapy and other systemic treatments. So there's collaboration necessary, but I'm also wondering if the public and the patients themselves, so this is all the top to bottom, but maybe we should also think about more information to the public that they can ask for this and that they can ask their medical oncologist, how about this other treatment? Would this be something for me? Is there, do you see any way to that?
Yeah, sure. First, the first question, yes, we absolutely need the medical oncologists because many patients have multiple treatment options. And I can say as a nuclear medicine physician, this patient could benefit from medical isotope treatment. But if I select this treatment, it also means not using another treatment. And that is a decision where I need a medical oncologist. So it's always a collaboration, very important, and we do this. But your other point is perhaps much more important. It's patient empowerment. If there is a new treatment, then the medical oncologists are not very likely to present it to patients because they cannot give it. The patient needs to ask for it. And in the Netherlands, we have a very strong patient community, especially for prostate cancer. They are very strong. And so they are now training patients when they have the diagnosis of prostate cancer. And be aware, if you have the bad luck of getting metastatic treatment-resistant disease at that point of your life, think about lutetium PSMA treatment and ask your medical oncologist. And that's working very well, and it helps.
Okay.
One sentence to add. If that moving forward in the treatment line happens, and it is happening, to give you an idea, Novartis is announcing that it would take their $1 billion a year Pluvicto to potentially $8 billion per year. That is what pharma does with the isotopes that you produce.
So we are reaching end of the time. It's very nice to see that experts engaging into discussion and question each other. So it's very nice. So thank you for this very exciting journey through nuclear medicine. I think you touch upon very important aspects, discussing also the challenges in front of us. Many of those subjects are discussed at, for instance, plenary meetings of the European Observatory on the Supply of Medical Isotopes, which is co-chaired by my organization with the Nuclear Association of Nuclear Medicine. So if you would like to be engaged, you would like to know more, feel free to talk to me at the margin of the meeting. If you would like to see this subject from another perspective, from the high-level perspective, so you have opportunity next week, 27th of April, there is a high-level workshop on security of supply of medical isotopes. I guess the link was posted on the chat, so also there is an opportunity. Those of you who are staying for the RRVM, I wish a great conference. My wish for the organizer is that maybe next year we can also think about such kind of nice event to further make the visibility for the subject of medical isotopes. And I would like to also thank ENS for the organizing it. Thank you very much.